Welcome everyone to this Women's Health Champions launch webinar. My name is Marika Dam and I'm the Increasing Reproductive Choices project worker at Women's Health Champions. And today, Women's Health Champions is very proud to launch the Increasing Reproductive Choices Research and Evaluation Report 2020. So with me today are Milica Markovic from the Department of Health and Human Services, who will launch the report. Associate Professor Louise Keogh from Melbourne University, who's an expert in the field of health sociology, who has developed the research report for the Increasing Reproductive Choices project, and Dr. Patty Moore, Head of Abortion and Contraception at the Royal Women's Hospital. So also with me today are Marianne Hendren, the CEO at Women's Health Champions, my co-worker Shannon Hill, who's the Sexual Health Advisor in our Ballarat office. So Shannon has a wealth of knowledge in sexual health and is the go-to person for all your sexual and reproductive health questions. And she will also be assisting us today in the Q&A session. And we also have Deb Harris from our Women's Health Champions team, who is our Zoom tech guru for this launch today. So just in case you have any questions, please enter them in the chat box on the bottom of your screen. Your questions will be private and we will try to endeavour to answer them at the end of the webinar. Just to let you know also that this webinar is being recorded and it will be available on our Women's Health Champions website in the next couple of days. So before we start, I would like to acknowledge the traditional owners of the land on which we meet. So for me here in Horsham, those are the Watchabollock, Jadwa, Jadwajali, Wagaya, and Japakult people of the Kulin Nation, and I would like to pay my respect to elders past and present. I would now like to introduce you to Milica Markovic from Prevention and Population Health at the Department of Health and Human Services, who will officially launch this report. Welcome, Millie.
Thank you very much. Good afternoon to everybody, and thank you for inviting me to be with you today. May I also start by acknowledging the traditional owners of the lands and waters on which we are meeting today and pay my respects to their elders past, present and emerging. Women's reproductive health choices remain as important today as they were some years ago when Victoria started its journey on removing legislative and structural access barriers for women's reproductive health. Focusing on the more recent past, I think we all celebrated the abortion law reform in 2008, which decriminalised abortion in Victoria, and many of you who are with us here today have contributed to advocating for that landmark legislation. Similarly, you have played a significant role in crafting and implementing Victoria's first ever Women's Sexual and Reproductive Health Plan, which was launched in 2017, which again identified reproductive choices as a key priority. And let's not all forget that we celebrated the Australia's High Court decision, which upheld Victorian and also Tasmanian women's rights to access to abortion services without fear and intimidation. Of course, none of that would have been possible without women's health organisations, researchers and others advocating for that fantastic outcome. As many of you are aware, since 2017, the Victorian government has progressively established 8 women's sexual and reproductive health hubs, 4 of which are based in regional Victoria. They're based in community health services, they provide anonymity to women and offer clinical services, including long-acting reversible contraception, medication termination of pregnancy, and sexually transmissible infectious testing and treatment. Establishing hubs in regional Victoria was, of course, in recognition of the need to increase women's access to these services. These days, sadly, because of the pandemic, the Commonwealth has delivered a telehealth reform, and that has reduced barriers to women in regional Victoria and their experience in accessing sexual and reproductive health services. This radical reform was delivered quickly in the early days of the pandemic, and we're still benefiting from it. However, as you are all aware, the Commonwealth has indicated that over the next 12 months, it plans to review the current access to telehealth and wants to restrict these services to GPs who have had an ongoing relationship with the patient in the previous 12 months. Knowing that not all of GPs in Australia, and for that matter in Victoria, provide these services, I trust that all of you will be advocating for the reconsideration of this policy change the Commonwealth has proposed. We know that while hubs have, to a significant degree, contributed to improving women's access to regional Victoria and elsewhere to women's reproductive health, this is not sufficient, and we need greater involvement of local general practices. And I'm grateful that Paddy Moore, our Royal Women's Clinical Champion, is here with us, because together with Kat Hannon, she has contributing and is continuing to contribute to providing training and support to our local health providers so we do better and remove these barriers. Clearly, we also have Family Planning Victoria, and together with the colleges of general practices, we are hoping that you are all seeing the benefits of that investment in our efforts to improve women's access to services. I would like to congratulate Louise Keogh, with whom I worked once upon a time at the University of Melbourne, for putting together this report, which has clearly demonstrated that people are feeling that we have made a difference. Of course, we will not stop there, and I trust that all of you will contribute to our efforts in the future. Thank you.
Thank you for that, Milika. I would just like to give you a quick overview about the Increasing Reproductive Choices program and how it came about. So in 2017, Women's Health Grampians and Melbourne University have conducted a baseline research to better understand referral practices for unintended pregnancy options and abortion. And after that research, the Department of Health and Human Services funded the Increasing Reproductive Choices project to help ensure women had access to reproductive health services in the region where they reside and work. So the aims of the project were to identify, strengthen, and improve awareness of referral pathways for sexual reproductive health, medical termination, and other abortion services, and to improve general knowledge in the region with respect to abortion services and the legal obligations, and to develop an evaluation framework to ensure that the outcomes of the project could be shared with other rural areas as well. And about the evaluation project, that's where Louise will be telling you a little bit more. So I would now like to introduce you to Louise Keogh, who is an Associate Professor in Health Sociology at the Centre for Health Equity at Melbourne School of Population and Global Health. And she will talk a little bit more about the research report in detail, including methodology, data collection, analysis, and recommendations. Thank you, Louise.
Thanks, Marika. Thanks, and I'll acknowledge the traditional owners of the country on which I am residing, which is the Wurundjeri of the Kulin Nation, and pay my respects to elders past, present and emerging as well. It's a pleasure to be here, and I've very much enjoyed working with Women's Health Grampians. So it's great to be able to present the results of this research. I'll go to the outline slide. Next slide. Yep. So I'm going to start with how the two surveys compared and reflect on, we're going to look at some reflections on the Increasing Reproductive Choices project and what we can learn from the case studies that we conducted. And I'll finish with recommendations. Next slide. So we conducted a baseline survey in 2017, and what this revealed was that services were quite severely limited, abortion services or any services to support women with unintended pregnancies. There were surprisingly high rates of conscientious objection among GPs and a lack of clarity about what the options were for women and referral pathways. Next bit of the slide. So in response, the Increasing Reproductive Choices project was started, as Marika has mentioned, and she was the person who conducted this project, was really to address some of the things that we found in the survey that were barriers to increase referral pathways and improve just general knowledge with respect to abortion and the legal obligations. And so we were able to repeat the 2017 survey after the Increasing Reproductive Choices project had been running for a while, to really see if any change had been made. So this is quite a unique opportunity to have conducted the survey, then do the project and then redo the survey. So it really gives us a chance to see what changes have been made. So we sent the short questionnaire online and postal versions, and it was sent to all GPs, sexual health nurses and practice nurses in the region. And so we're able to repeat the questions we'd used in 2017, but we were also able to introduce some new questions specifically about what changes they'd noticed in the 12 months. So I think that was when we sent out the survey, it was 12 months that the project had been running. So a bit about the survey participants. In 2017, we had the same response rate actually in both periods, but in 2017, because we only sent the survey to GPs, there was 84, we had 23 GPs, so that was 27%. In 2019, because we'd expanded who we sent it to 103 health professionals because we included nurses, and we got 28. So again, the response rate was 27%, very consistent. The sample in 2019, oh, these are old slides, oopsie. So we had 19 doctors, 4 nurses, and 3 were other. So that included receptionists, practice managers, and a medical student, and 1 person declined to answer. So that was the full range of people that we had, and we had similar numbers of males and females. Next bit. So that slightly more than in the previous year were in that older age group of over 55, 74% compared to 50% in 2017. And they'd worked in the region for, on average, 13 years. 12 had trained in Australia and 13 overseas. So in the original survey, we had 65% of our sample trained overseas. In this sample, it was just over 50%. Next slide. So the main part of the survey asks, what do doctors do when women present with an unintended pregnancy? The 2019 sample, the doctors we spoke to saw more women presenting with unintended pregnancy than in 2017. So they saw on average 5 as opposed to 3. So our sample was capturing people who saw more women needing with an unintended pregnancy. And we asked them, what do they do when women present? And these are the numbers comparing 2017 to 2019. Future contraception, in fact, it was a very high in 2017, but perhaps it's always not the best time to be asking women about this when they're presenting with an unintended pregnancy. So it was kind of good that we saw this go down to 61%. It might be appropriate, but we wouldn't assume that's always the most appropriate thing to be talking about in that first consultation. Pregnancy option counselling and STOP were reasonably similar. The thing we were very pleased about, if you just click the next thing, is the increase in the people who were talking about MTOP, which means they always discuss this in that first consultation. It was very low in 2017 at 27%, and the reason for this was that some doctors weren't really aware that MTOP was an option for these women. So we were very pleased to have that go up to 43%, which is highlighting that they're more aware of MTOP as an option and more likely to discuss it with women in that first consultation. Also, a slight increase in teleabortion, but still quite uncommon. So conscientious objection, this was surprisingly high in the sample from 2017. 38% of GPs sometimes or always referring due to a conscientious objection. And when we looked only at the overseas trained doctors, this went up to 62%. Sometimes or always referring due to a conscientious objection. And we had 1 male participant who claimed to hold a conscientious objection, but didn't offer out any referral, never discussed MTOP, never discussed surgical abortion, and also didn't refer. There was some suggestion that there were doctors who weren't adhering to the referral practice. So when we go to the data from 2019, and this is an old slide, so I'll give you the updated numbers, they were less likely to answer this question. So 7 non-responders to this question, and we pondered whether that was due to potentially not liking the media around the high rates of conscientious objection in this region. There were 3 doctors who didn't respond. And the other reason for non-responding was perhaps receptionists, for example, may not consider that something that they have a right to claim. So 2 nurses and 1 other also didn't decline to answer that question. 24% of those who did choose to answer this question always or sometimes referred due to a conscientious objection, so lower than the 38% we'd seen previously. And 5 of the 9 overseas trained doctors sometimes or always referred due to a conscientious objection. So rather than 62% from 2017, it's more like 55% of overseas trained doctors sometimes or always referring. So a slight reduction there. So open-ended. So we also ask these open-ended questions. What are their opinions of the services in their area? And once again, this was a question that was repeated, so we were able to compare 2017 to 2019. And pleasingly, fewer people said that there were limited or inadequate services. So that sort of quote would be, it can be a problem if you're very young and you are not able to travel. Also, if you're needing surgical or if you have no Medicare, which has been an issue cost-wise for our women. So comments like that saying that there's inadequacies in the provision was slightly less than in 2017. A lot more saying okay or good or improved, which is really positive. Becoming available in the region after medical termination offered by a GP in town, very good support, and just 7% unsure. So local O&G, not keen on terminations, not aware of other local options, I usually refer. Next slide. We also asked them, has there been changes in the last 12 to 18 months? And pleasingly 60% felt that it had improved, so increased options and range of services, while 40% saying no change, that really the problem is the same. So obviously not all the problems are solved, but good to see that feeling that things have improved. With respect to referral pathways, a similar number. If you just click the next slide. Again, 60% felt that referral pathways had improved, and particularly the health pathways were noted as helpful. And yet still that's same commentary, not available unless you're prepared to do it their way. So some people feeling that really there hasn't been any change. And I think it's important to acknowledge both of those perspectives. Interestingly, only 36% thought that the training options had improved, with the majority reporting no change or that they were unsure about the training options. And this is surprising because I think Marika did a great job of providing a lot more training than had previously been on offer. Next slide. Interestingly, when we ask where is the improvement most desired, MTOP you can see is the largest there, indicating that despite that being the area where we made the most progress, that there's more awareness of MTOP and more willingness to talk to women about it, it's also the area that most improvement is desired. You'll also see training and surgical termination of pregnancy there as the big ticket items in terms of what people are most interested in seeing improvements in, and a number of other things there which you can read as well. So we did some case studies to find out in a little bit more detail what had gone on and what had worked. So if you click these slides, so we talked to a nurse, a GP and a pharmacist, and when you look at their perspectives together, the things that they felt had really helped them to be part of getting new services started was networks and support. So having, and this is networks close to them and networks far away as well. So people in the region are needed to support these services because they're very multidisciplinary. You need the ultrasound, the pharmacy, the nurse, the GP, the receptionist, pathology, all on board, all working to deliver, for example, an MTOP service. And so it came through in all of these case studies that that local network was a real enabler to getting services set up. But also the wider, more distant network, which is where you have experts in this area who can give you the resources you need to get your service running. So Gateway was mentioned, the Women's was mentioned, and the MTOP providers down under Facebook group was also mentioned. So really needing that broader, more distant network to support this process. We asked specifically about backlash because when we talk to people about MTOP delivery, often the concern is that there will be a backlash. So we specifically asked people who had been part of setting up new services, had there been a backlash? All were expecting some backlash, but none was reported. They did experience a personal judgment from other healthcare providers, but that wasn't perceived as the kind of public backlash that they might have feared. So in general, their experience was really positive, and so I think that's a great thing to learn from. And next slide. So we collected data in multiple different ways. So we got the case studies, we did the survey. We also asked the reference group who had really guided this project the whole way through to reflect on the whole project, the whole Increasing Reproductive Choices project. And we asked them what had worked well. Sessions with Patty Moore comes up a lot, and you're going to hear from Patty in a little while, but everybody felt that those sessions had been held just at the right time in the project. They were a real turning point for the study and particularly valuable for debunking myths and explaining the law. There was discussion about the way that Patty was able to really make it clear and present things and debunking a lot of those myths that often hold back perhaps providers from thinking about delivering MTOP. The reference group was considered a real key to why this project worked well. It was a group of passionate people. They're all local people, all working directly in this field. They were consistent, committed, they shared information, and they used their networks to really support this project. So the reference group guiding the project the whole way along was considered the other key thing that worked really well, and funding. The project wouldn't have happened without funding. So the project worker, Marika, was key to the success of the project, and she was able to support clinics wanting to set up services and arrange the training. So having that funding dedicated to this project was really key. So I think without those three things, I'm not sure that the project would have achieved as much as it did. In terms of challenges and barriers that the reference group reflected on, there was some disappointment that GP, even though they'd be enthusiastic at trainings and workshops, perhaps didn't follow up as often as they would have liked. So that might need a bit more teasing out as to perhaps what happens when they go home, back to their clinic. Are there further barriers they encounter there, even though they were perhaps positive in the workshop? Health professional obstacles continue. So one of the misconceptions that was raised is not understanding who needs abortions and why. The misconception that it's young women having, unprotected sex in inappropriate settings, whereas actually the most common abortion age is more around the 30 age group. So that sort of misinformation about who needs abortions and why was one barrier potentially. The actual practical practice barriers around accessing ultrasound, having a supportive pharmacy are obviously really key. And just not having enough GP providers to have good pathways. And finally, the concern of the reference group was really about the sustainability of the project. All are very committed to this work and we like to continue. I think they feel like they've made some progress, but there's much more to do, and are concerned about once funding ceases, will they be able to continue? So in summary, I think the biggest impact has been on medical abortion services. There are more services now, and we have shown that seems to be more GPs talking to women about that option, which is a really positive thing. We seem to have made some impact on GP knowledge, medical professionals' knowledge and awareness of MTOP, but that's also the area that participants want to see more change. So it's not like we've fixed it, it's like we've made a little bit of progress and we've actually revealed a big need that there's a lot more work to do in terms of improving access to medical abortion in this region. So work has to keep going, and I think what hopefully I've shown is that the strengths of the project were an active reference group who are very embedded in the community, a very proactive, a funded project worker devoting her time entirely, or her funded time entirely, to this work, and support from the Women's Hospital, the Gateway Health Service in Wodonga, and the Sexual and Reproductive Health Clinical Champions Project. So having all of those pieces, I think, is what's made this a strong project. And finally, the recommendations. So these, if we can go to the next slide, these are the recommendations that are made by the reference group upon reading the evaluation report and seeing what has been achieved so far. And I guess it's no surprise that they want to continue this work, maintaining hopefully the reference group, but also some funding to continue to facilitate access to really improve the workforce. This is where the work needs to happen. The workforce development opportunities need to continue locally. Support, like emerging medical abortion providers do really need a lot of support to get up and running, and potentially there's some bigger issues that need to be advocated for around the actual financial viability of medical abortion provision, for example, MBS billing codes, for long consultations, also for nurse time to support medical abortion, and setting up telehealth for GPs. So there's some more strategic issues to address, as well as just the support and ongoing training required. And as I said, the reference group would like to be maintained, and they can do things like monitor the provision in the region, provide expertise and knowledge to peak bodies, and to continue progressing this work. And I think that's all I have. Thanks.
Awesome. Thank you very much for that, Louise. Thank you, and both you and Casey, for your
Sorry,
wonderful...
I should have mentioned Casey, my very hardworking research assistant who did a lot of the hard work on this project, and I think he's probably listening in.
I think she is. So thank you both for a wonderful job, and for gaining all the data and analysing it and actually making sense of it all as well, and to see it, you know, coming together so nicely. I also want to just mention that the full report will be available on our website after this webinar, and also that the participants to this webinar will be sent one of the reports in their email after the webinar. So we will follow up with you on that one. So I'm very pleased to now introduce Dr. Patty Moore, who is the head of abortion and contraception at the Royal Women's Hospital. She's a leader in the field with a wealth of knowledge when it comes to sexual and reproductive health in general, and abortion and contraception specifically. And Dr. Patty has been a great supporter of the Increasing Reproductive Choices project and is a mentor for many. And we've had great opportunity to work with her lots during this time. So thank you, Patty, for being here today.
My pleasure. Now I'm going to attempt to do a webinar with the mask on, because my co-conspirator Kath Hannon is also in the room. Show your face, Kath. So, and I want to acknowledge Kath as doing most of the groundwork with the Clinical Champions project. And so before I start my talk, I would also like to acknowledge the traditional owners. And in my case, this is the Wurundjeri people of the Kulin Nation and the ground on which we stand today, and pay our respects to elders past, present, and emerging. If people can't hear me, please let us know, and Kath can go remotely and I can take off the mask. But I kind of like the air of mystery about it. Now, do you advance or do I advance? Thank you. The title of mine was Access and Equity to Reproductive Choices, COVID and Early Medical Abortion, Tying It All Together, which is a kind of a bit of a big ask. And we've kept this broad brushstrokes. My talk will be quite broad brushstrokes, quite a bit of it about observation of what's happened in 2020, and ending up with some unanswered questions and some research possibilities. So I'm just going to frame it in images. So if we could go to the first image first, go back one. Yeah, so as has been mentioned, Kath and I have been involved over the last 5 or so years in education of GPs, practice nurses, and nurse practitioners, and community advocates in having the conversation about abortion. And as Louise said, who needs abortion? Why do we need an abortion service? Why must it be localized? Why should it be responsive? Why should it be patient-centered? Having those conversations together with rolling out an education program. And that became really possible when it was possible to get a script for mifepristone and misoprostol to have an early medical abortion on the PBS. And that was the real momentous watershed when it could become quite democratic, the way that we rolled out this model of abortion. In other words, it could be embedded in primary care. And this is an example, this photograph, this is from Horsham. You can see it's early evening with the shadows, and you can probably tell that it is summer. I just want to frame that Kath and I drove through an active bushfire that day to get to this meeting, and we were met with a lot of emotion and a lot of welcome when we got there. And on the way back, I remember saying to Kath, gee, I hope that's as hard as it gets for Victoria. And that was in 2019. And if you look at this picture, you can see the first picture again. You can see we're not socially distancing really there. And now we have to. The other thing I remember about that meeting, and for me, it was a very important meeting because there were a group of people there who were conscientious objectors, and they felt that they could talk and they were welcomed to talk. And it became quite a useful conversation. So that was sort of embracing the philosophy that we have, is that we don't exclude, we allow a conversation, and then we educate those who are willing. We don't force anyone to be a provider. So you can go to the next slide now, and this is an acknowledgement that I haven't got a screenshot of an active webinar that we've been doing recently. And it's very obvious because there are several people drinking and having far too good a time on this screenshot. But it was just to illustrate that we now do all of our network meetings on webinar, and we have adapted to this quite well. I think that Marika's going to mention that we are going to continue to roll out this model. So in the time of COVID, we've had to come up with new solutions. Now, Kath and I absolutely adore traveling to regional centres, and there's no substitute for actually meeting the practitioners. And I think there's something incredibly validating about going to a place, warmly congratulating the people on the ground there about the work that they're doing, and establishing a link, a collegial link. And it's not as easy to do that if your first interaction has been on the internet. So I just wanted to put that out there. But despite that, we are working quite well on this medium. And I noticed that today we've got 41 participants, or 42 there were before. That's fantastic. On our networks, we're now getting more and more each time, possibly more than could attend a meeting after a busy day in a GP practice. So there are some pluses and some minuses of that. You can go to the next slide now. So I'm using the same slide as Louise, just to to acknowledge the talk before, and this is a reminder to say that was fantastic, that bit of research. Lovely and beautifully presented. Thank you so much. Just showing how things do change. And again, I wanted to draw that the MTOP is the biggest word there. And as Louise was saying, there was still very much a flavor in the research that this was the area that people wanted to hear more about. And so at the risk of creating a very bad pun, I'm very excited about this, because this shows that the ground is still very fertile for us to go back again. Sometimes we don't know if going once is enough or if it's too much. We have a philosophy that we go where we're invited, and we do have a very much an interest in doing a follow-up with the places that we've been before in an interval, a responsible interval. And so it's great to know that they still want to hear more about MTOP, that we're not just banging on ad nauseum about it. You can go to the next slide. So these are some observations about how we find things in 2020. And I've entitled it deliberately, Access in the Time of COVID-19. And there have been lots of challenges in this time. And I think that one of the things that I have sensed in some of the advocacy meetings that I attend is that there is a narrative that things will necessarily be made worse by COVID-19, that the barriers will be enhanced. And I think that that would have been how I would have felt about it initially, that things will get much harder for all women everywhere. But I just want to say that I would mediate that with some observations. What certainly has been harder is, how do you get a diagnosis of a pregnancy if you're in lockdown? And just thinking about a patient being able to leave home, get to the chemist or whatever to make that diagnosis, or to get a GP visit. And I think back to the times when I was a younger doctor, and I did work for several years as a rural GP. And I have very clear memories of young women coming with serial sprained ankles to meet me until they got up the courage to tell me that they were pregnant and they wanted an abortion. And try having that rapport with someone over telemedicine. I think it's, you know, once you start thinking about those barriers, it'd be really difficult. So diagnosis and decision making, 1-800 My Options has, as you know, is our statewide information, internet and phone service. They've reported a big increase in the number of people requesting help with decision making and options counselling during this time. So that's very interesting to us. It's different than the narrative of more abortions. It's different than the narrative of there being more obstruction, but there's something happening there. Delivery of services have definitely been challenged, and we've been aware that there have been difficulties delivering a service when a GP practice is under threat and having to change everything and turn everything to telemedicine. Particularly some of our metropolitan services dropped off sexual and reproductive health as being too hard, and they had to deal with their other chronically ill patients and their aged care patients. So the delivery of services has been difficult. As a tertiary hospital, we've also been aware of that we have put a lot of screening in place. We've asked people to only come if they really have to. We've asked them not to come with their supporters, and many regional services have had to operate in the same way. I want to mention also deployment of staff. So in many of the regional areas and in some of the metropolitan areas, nursing staff and admin staff have been called off to do screening clinics or to be involved in contact tracing. And so quite a number of the services have really decreased as their staff has been deployed. And of course, we're all dependent on the human resources that make up our staff. And I'm just aware, for example, of the early clinic development in Frankston, one of the hubs areas, and then Frankston has really been bowled over in the last 10 days or so with a very big outbreak and 700 staff furloughed there. So all of a sudden a development might be knocked over. And the other thing I want to mention is, and this is in no way whinging or a pejorative comment, but DHS guidelines and regulations as a state grapples with public health and putting controls around a pandemic has meant that we've had to change how we've practiced over the last 12 weeks, almost on a weekly basis. We've had to change the screening techniques we've put into place. We now have to have COVID testing results on every patient who would go forward for surgery, for example. Now that's had presented some difficulties, but it's also presented a lot of opportunities. And we can go on to the next slide and I'll talk about those. And so I guess my pithy title for this is COVID crisis theory. So based on that idea that in a crisis creates a whole load of simultaneous circumstances out of which creativity can arise and new opportunities develop. And going back to one of Louise's findings was that practitioners really find that if they had a support structure and a network, that things were more possible. What we've noticed with our webinars and our online networking is that collegiality, if anything, has increased in a really good way. Some people have described it as the blackout phenomena, that, you know, when people are under the pump like this, they really do know where their colleagues are and where their allies are. And that those groups that have managed to continue providing a sexual and reproductive health care service, and particularly medical abortion, have mentioned that they've had support from colleagues in their community. And the resources that we have made available previously to help doctors upskill, we've seen an increased uptake in people wanting to be involved rather than people backing off. So there might be some centres that are closing, but for others, there's a sense that there is an obligation on them to provide it locally, because they know that there isn't going to be a surgical solution necessarily. And the models of sharing the care across services that we have seen have been really very valuable. And I just wanted to make a shout out to several models that we have seen working really well. There's a shared care model where nurses in Bendigo do the initial consultation and then send electronically the rest of the consult to a GP who's in Castlemaine. And then they, via telemedicine, have been finalising consents, etc., and delivering the service more locally. And also in Horsham itself, if we go back to Horsham, the original place that we mentioned, Dr. Gary there started his work around about 2019, but has increased it in response to his reading of the situation where women are not going to be able to travel. And he and his practice nurse are really, Sharon, are really increasing their service. We've also seen really great, in the last 1 month, great collegiality in the Swan Hill region between the Aboriginal Community Health Service and the hospital-run Community Health Service, in no small part because of the incredible ongoing work of the nurse involved in that service, in those two services, but also the medical director at the hospital there. So a lot of really good good work. Yeah. And we can go on to the next one. And these are really observations of ours from the front line, if you like, not just from our service, but we've also drawn a little bit on the information that we get from 1-800-MY-OPTIONS. And that service, while it's provided a really important portal for women to access information directly, so they don't have to go to a GP or other health service to get information about where to access a medical abortion or a surgical abortion if that is their choice or what they require. 1-800 has also provided a great source now of data in terms of the demographics of who's accessing information, what gestational age they are, what part of Victoria they're from, and what sort of services they're looking for. And I've also talked to my colleagues in private provision practices about our referral patterns. And actually, during the time of COVID, we've noticed in the second half of this year that the referrals, the requests for services have really decreased. So private clinics are running at about 40% of what they used to. And that can be really easily understood in terms of the populations have shifted dramatically. We don't have the same numbers of overseas students that we did before. People have returned to the state of their origin, if you like, and people have returned home. And we've also noticed that at the tertiary hospital, that our number of referrals have, with each progressive lockdown, have gone down a little bit, and then they come back up again as the lockdown persists. One of the things we'd been concerned about was that we thought it might be really difficult to get diagnostics, so to either blood or swabs, or in particular ultrasounds. And there are other diagnostic services such as Breast Screen Victoria, which have really closed down in these times, but surprisingly most ultrasound departments stayed open. And so we find that there was pretty much stable access to diagnostics. We know that rural women in particular do quite often have the barrier of there not being an ultrasound service, easily acceptable. You know, some people are driving up to 1 and 2 hours, but it didn't seem to have been the big barrier. The other thing was that there has been an increase in requests for options counselling, as I mentioned before, and so 1-800 have also mentioned this, and we've seen an increase from it's been steady for about 10 years of about 8% of women who access our service wanting options counselling, and it's now up at around about 40%. So that's really interesting and something that I think needs interrogation. There's been an increase in the preference for non-surgical, and again, this is explainable in terms of avoiding surgical options, which would involve a general anaesthetic in most services. And we know that this is a particularly hazardous thing, particularly if someone is COVID positive, and presents a whole load of other challenges. So we have noticed in our service an increase in the numbers wanting medical abortion, and we've also noticed that within both our metropolitan providers and our regional providers that the numbers have gone up very markedly, the proportions. What we've also noticed in our metro services, and I'm talking not just at our hospital, but at the other public hospitals that provide surgical abortion, is, as with each lockdown progresses, an increase in the gestational age. And that can be understood in terms of patients not necessarily, or women not necessarily being able to get the pregnancy diagnosed early, or being more reticent to come forward, or requiring time to think things through a bit more. So those are the observations we've had. And next slide, just to wrap up. So I've really probably raised more questions than I've answered. And I think the thing that I've been thinking about and meditating about the most is that we don't really understand what women's lived experiences during this time. And I think that that would be something that would be really interesting to be able to explore in some way. What are the factors in decision making in the context of a pandemic? Women are expressing more ambivalence to us. They're expressing more uncertainty about the future. Is this a resonance with what's happening on a societal level, that there's a huge uncertainty about the future? We hear reports, and they're valid reports, but we don't have actual raw data about the increase. We hear reports about increase of requests to support services for family violence and intimate partner violence. But again, I think that could be an area that was interrogated more. And we've reported anecdotally, we've heard some research about increased rates, but is there a shifting attitude with regard to requests for medical versus surgical, both within our medical community? Because I would certainly have been at lots of talks previously where GPs and even ONGs, my colleagues, would be saying, but you know, medical's not as safe. And is there a shifting in our thinking? And is there also a cultural shift in the acceptability of it here in Australia? When we think of Northern Europe, where 60 to 70% of women would typically choose a MTOP versus 20 to 30% here, are we going to see a shift now? And that would be really interesting to interrogate. And contraceptive need, has the baseline changed? Are more women wanting contraception in this time but not able to access it, or is it less, in fact, that are wanting it at this time? And finally, and just the last slide now, yeah, which is your comments and questions, and thank you for your attention.
Thank you very much for that, Patty. To me, that really highlights how important it is to keep doing this work, and how, you know, we think we have things sorted and then things change, and we need to pivot our work to make sure that it still works for women and that they can still access services as close to work and where they live as possible. So thank you for that, and I'm sure there'll be heaps of questions at the end. Just to quickly recap some of the recommendations that came out of the report before we go into our Q&A session. So Louise has already touched a little bit about this. So one of the things was that a recommendation for future work, that the reference group is going to be maintained to actually keep focus on sexual and reproductive health and increasing reproductive choices. And to maintain capacity, especially in the region that we've been working in, Grampians, Pyrenees and Wimmera regions, to make sure that we can advocate, liaise and promote communication and partnerships within this area with the Department of Health and Human Services, with Western Victorian Primary Health Partnership, but also with other key stakeholders that we've been working with in the past. Another thing that was a recommendation was that sexual and reproductive health service provision is being monitored. So we can do that with our reference group, but a very important part of that is also our 1800 My Options website that comes from the statewide peak. And they actually have a really good overview of all sexual and reproductive health services within Victoria, including medical termination and surgical termination. So if you are wanting to know more about service providers in your area, please follow the link. We will have it up in our slides in a minute, but they have really good information, including of the new services that have emerged during the time of the project. Another recommendation was suitably trained and sustainable workforce that has access to training and MTOP training. And Kath and Dr. Patty have been working on the Clinical Champions project, and they've been working on future MTOP sessions coming up. So Dr. Patty has mentioned that a little bit before already. We are now looking at different ways of delivering that. So that might be an online session, but that work still continues. So please keep an eye on future communications when it comes to this, because that will be very current. And the last one is that we want to have rural and regional expertise and knowledge and advocacy that we can use towards peak bodies that have a decision-making capacity in this field. I'd also like to mention that Women's Health Grampians is working on an information video about termination of pregnancy, and that will be hopefully launched soon. So please keep an eye out on our website and in other forms of our communication for that specific piece of work. So I would like to now go into our Q&A session. So Shannon, have you got any questions for us that might be asked to our panel?
I do have a couple of questions, and I might jump to Louise first and let Patty catch her breath. Great presentations. I had a question, Louise, about people were very happy to hear about the improvements, but how do we keep focus on this service, so I guess sexual and reproductive health, so that we continue to see improvements in service delivery and referral pathways? So that might be a tough question between Louise and Marika.
I think if this work has shown anything, it's shown that it does need some dedicated people actually committing to this work getting done. It isn't going to get done if we just leave it to chance. And I think, like Patty said, I think what we've shown is it is really fertile ground that we've been able to make some progress. So it would be crazy, I think, to not continue to invest in this area and having someone like Marika able to really focus this work. Marika, did you have?
Yeah, I agree with that, Louise. I think it's important to have somebody on the ground, and local partnerships often require a local person on the ground, which makes partnerships way easier. And we have got amazing stakeholders that we've been working with within this region that are passionate about this work. And I think it's important to keep that going and to keep the conversation going about options.
And we also had a question, Louise, about the data. So is it possible to break the data down into smaller townships, if you like, for Stawell, Horsham, Ararat?
So no, we didn't. The survey is anonymous, so we don't ask for those details about the participants, and because they're small numbers, I think it would be tricky to do that anyway. So no, sadly, just that high level summary is all we have.
Thank you. And we have, perhaps this could be a question for you, Paddy. In your experience, do you feel like the fear of backlash often comes up when we're looking at trying to encourage new providers into medical abortion? Do you feel like there's something that we can do to understand perhaps this fear of backlash, or do you feel like it's a barrier or to providing medical abortion? I might have you might be on mute, Paddy.
Talking a lot then. What I would say is the most powerful thing I have seen on this topic was allowing people to express their fear of a backlash in a meeting and not be laughed out of the room, or somebody from a metropolitan service like me who works in a hospital and nobody knows what I'm doing and it's so easy for me to do my work, not putting them down, but actually listening to it and asking where it comes from. It comes from things like my daughter plays netball with the woman who's the pharmacist, and she's a practicing Catholic, you know, and they know all this stuff about each other, you know. They also know all the ways around it as well. And so usually having that conversation in each area, and this is where the power of going local, whether it be with a local webinar or actually traveling out there and getting people to meet each other. I can remember a meeting we had at Shepparton where people who'd worked in parallel for 20 years met each other for the first time and then could support each other. So being allowed to express it, acknowledging that it's very difficult sometimes to live in a small town, but with it comes these other lovely sometimes opportunities, and providing a community of practice for those who do decide. So I think Louise mentioned this fantastic group called MTOP Down Under Doctors, which is a lovely name. They really function as a support group, some information, but mainly a support group for each other. And then there are other more local groups than that. So having support, I think, is the best panacea for that.
Thank you. I might ask that, Louise, I know you've done a bit more research on the topic. In terms of conscientious objection, do you feel like there's anything, is that a future thing that we need to explore more about? It's often difficult. We hear about women being perhaps blocked from their first appointment and needing to find a doctor who's supportive. I'm wondering what more we could do to overcome that as a barrier for women.
Yeah, thanks, Shannon. You know, this is one of my passion topics. I currently have a large grant application in to really study this in a lot more detail, because my assessment as a researcher, obviously not as a practitioner, but that we don't really have the balance right with the current legal settings that we have. The emphasis is on the protecting the moral integrity of the doctor, and so they don't have to do it, but then the sort of backup is they have to refer. And I think this study shows that that doesn't always happen. And I think with something as important as this, with the consequences for women of not being able to access the service, I just think we need a better mechanism. So I think about it from a research point of view, and I'd really like to explore better mechanisms for still protecting the moral integrity of doctors. I don't think anyone should be doing something that makes them morally distressed, but I think ensuring that women can get that service is important too. So I don't think we've quite got it right, but yeah, I think about it as a researcher, and maybe Paddy might have more practical ideas about what should be done.
Yeah, I guess I could sum it up in, you know, bypass the unwilling is the way I would think of it. And it's actually not compulsory to have a GP referral in order to access abortion services, but many women think it is. So I think there's a lot of education to be done at a really basic grassroots level, and at the same time continue to fund your publicly funded information platforms. So that women start to realize, because I think if you asked like a group of 1,000 women, most of them would say, but again, here's another research question. Most of them would say you have to go to see a GP.
Yeah.
It'd be interesting even to do that, wouldn't it? Find out what the majority of a large group would think is their first step.
Yeah, and I think 1-800 My Options is a really good way of achieving that, like teaching people that you can go through the website. You don't have to go through your GP. So
yeah.
And an absolute game changer for us, and we're hoping that our abortion video goes some way to putting the information in the hands of women who need it. Thank you so much. I think I'll flip over to Marika to do the next bit.
Perfect. Thanks for that, Shannon. Much appreciated. I would now like to introduce you to our CEO, Marianne Hendren, who would just like to do some closing comments for today's webinar.
There she is. I love her.
Thanks, Marika, and thanks to everyone. Look, I realise we are very much out of time, but I was really delighted to have the opportunity to just come in on the end of this and express our appreciation for the efforts that everyone has put into this piece of research, which, you know, is something we see as another piece of a journey that we've been making. We've done a previous piece, we've done this one. I was delighted to hear Patty and others make suggestions around areas that we could focus on in future research, and I love your ideas around women's lived experience and the sort of the more complex and pertinent angles and aspects that we could take in regards to that. So really tuning into that. But look, I'm aware we're pretty much out of time. I think, is there a slide gone up with some contacts that you may be able to follow up on that include, as we've mentioned throughout, 1-800 My Options, also contact details for Shannon and Marika, and Kath's Clinical Champions Project. I want to express really sincere thanks again to Louise, and also to Casey Henning, her assistant in this piece of research. They really go above and beyond, honestly, what we give them. I can assure you, we get tremendous value, and it's a relationship we're keen to continue. I also want to thank Millie and Patty and Kath for your contribution to this particular webinar, and finally to sincere thanks to our staff, in particular Shannon and Marika and Deb, who's behind the scenes making all this work really well. Patty, you touched on this, and I really just wanted to highlight it once more, is that, you know, Marika is our sexual and reproductive health project worker up in the Wimmera region. It's really brave work. You know, she, I believe, has had to put herself out there on a lot of occasions in the sort of circumstances that you alluded to, where there may be backlash, or there may be judgment, and so on. And I really commend that bravery, and hope that we can, I agree with you that having people on the ground is really, really vital, and that helps to normalize these conversations, and, you know, to keep the issue a very, very much a living one. So I've gone way over time, and I'll be quiet now, unless, Shannon, there's anything else I was meant to say. No, that's great. So thanks everyone, take care, and we'll keep the conversation happening.